Hope you're having a great day. My name is Steve Forbush. I am the owner and sole proprietor of Orthopedic Manual Therapy Instruction, which is a continuing education provider primarily in the middle states, the United States, but something that is available anywhere. And I want to talk to you a little bit today about an area that has not been discussed very much in the last 40 to 50 years, and that's the area of visceral mobilization. And so we'll talk a little about visceral mobilization and soft tissue mobilization, but there's lots of research on this. It's primarily research that was done prior to the hollowing out of manual therapy literature in the 60s and 50s with the conflict with other manual therapy providers in the physical therapy arena and the medical arena. But what we do know, and I'm going to give you some examples if we can. I've had many women come in with pelvic pain and low back pain and thoracic spine pain that you really can't find much mechanical problem there, but they just don't move well. There's some other issues that are there. And when you go through their history, you're going to find that they've had two abdominal surgeries, or they've had some laparoscopes. They've had oophorectomy or a C-section for delivery of a child. And when those things occur, and when guys have wounds and other kinds of things where they've had problems, my dad had problems with bleeding ulcers, and he had some penetrating wounds in his stomach where they went in to repair stuff. When you have those, we as therapists think once it's healed, it's fine. Well, the problem is that think about what normally happens in an abdominal situation. Okay, we have two major systems within our abdominal chassis, and I'm going to call it that. People hate the fact that I call it abdominal chassis, but it's the trunk. It's the area between your diaphragm and your pelvic floor. But we have two major systems in there. We have the greater and lesser omentum. And those greater and lesser omentum, their purpose in life is to find wounds and seal them. The last thing we want as human beings is to have a leakage of any of our gastrointestinal contents into this visceral area. So we have a tendency to seal whatever is irritated or leaking. So a good example is if you ask surgeons that have been on people that have had multiple incidences of endometriosis. They'll say that when they finally go in to try to clean up the endometriosis, which are a bunch of uterine cells that are abnormally growing in multiple places throughout this abdominal chassis, right? They'll find that the greater omentum is stuck down in numerous places. Wherever there's a lesion, it seems to be stuck there to sort of seal that lesion. So think about that. That's going to affect the ability of the bowels to move, the normal peristaltic activity, but it's also going to really affect the ability of the person to move. So can you move your trunk on your pelvis? Can you move your pelvis on your trunk? Can you move your lower limbs? Think about the hip flexors and how they're attached to the upper lumbar area, and are they going to be affected with how they can move and what the hips can do? Is there going to be potential issues with neurological irritation because the scar tissue is around areas that might be nerve root related? So there's so many things we can talk about, but I'm going to suggest that it's something we need to consider as physical therapists. And so we don't get a lot of training on this in the physical therapy programs. I taught at the University of Central Arkansas for 16 years. And during those 16 years, I really didn't have much opportunity within the curriculum to teach visceral mobilization. But it's something that I've been doing in my practice for the probably 35, 36 years. And at one point, I had the general surgeons in my town of Gainesville, Florida, that were sending me most of their patients that they'd done abdominal surgeries or other surgeries on. And I found that I needed to get them to be better and heal better, and so we did certain things to make them better. And there's literature that supports this. If you take our course on visceral mobilization through orthomti.com, you would learn all this literature that supports this. I'm not going to spend gobs of time right now talking about that. But what ended up happening was I would do adhesion releases in the abdominal area and the pelvic area. I would do some scar tissue mobilization. And again, I don't do scar tissue mobilization the way other people do it. I actually do deep pressure and single directions to try to rip adhesions rather than massaging. I think massaging just really doesn't do much except irritate the superficial scar. And so we try to shear the scar. So think about a scar. It's nothing more than two pieces of tissue that are sort of mended together, but they have overlapping. I consider it the pick up sticks phenomenon. So when scar tissue is laid down, it's laid down in multiple directions to connect the tissues together. Your purpose in life is to move and to stretch, and when you do that, you lay the tissues down more parallel. But when there's tissues that are still vertical or in directions other than the tissues you're trying to mend, and they're interconnecting, you've got to shear those tissues so that the tissues can then move freely again. So we teach how to do that. If you do that, and I do these deep pressure releases, we found that most patients that had the adhesion issues got dramatically better within a very short period of time. And every therapist will say that. Everything I do is making people dramatically better. The reason that I can say that is that we had an occasional trickling of a couple people that came into the office that were individuals that had these post-surgical conditions of pain and discomfort or bowel abnormalities or other things that the doctors would send us, or they had pain in their C-section area, or they had, and when we saw them, they did enough better that the doctors then start sending all their post-surgical patients to the clinic. And that's sort of the telltale sign, I guess. It allows you to know that you're being effective at what you're working on. So think about it, that the whole purpose of visceral mobilization is to get the tissues to move the way they used to move. So if you have a knee problem and the knee is not moving well, the first thing as a therapist you're going to do is try to get the knee to move more normally. If you're working on playing with an abdominal area and how it moves, and it doesn't move well, and it pulls in one direction and not the other, and they can't rotate as far one direction as they can the other without feeling pull or pain in an area that's related to that, or they can't flex as much or extend as much because of that reason, or they have problems with their normal bowel habits or their normal other interactive habits they have, then to me there's something we need to deal with, right, as physical therapists. And I think too often we avoid discussing or thinking about that visceral area and what we can do as therapists. And what our purpose as physical therapists is to create motion, right? We know motion is lotion. We know that we can create more motion by breaking adhesions, whether it be in a knee or a shoulder or a wrist and a hand or an elbow. And we're doing the same thing in the visceral area. So again, if you're interested in learning more about that, if you're interested in trying to work on more patients that have these conditions, if you're thinking about it for yourself, you've had some abdominal surgeries and now you're thinking about doing more with that, then please look us up at orthomti.com and sign up for a visceral mobilization course. It's been great talking to you today.